Okay, so I think we can get started. So I'm Karen Brzezinski. I'm a member of the Mohawks of the Bay of Quinte and an anesthesiology resident at Brigham Women's Hospital. So thank you for joining us today to have a conversation about health equity, what we call Health Equity and Native American Summit. So today we're going to have a lot of programming from a lot of different speakers about pipeline programs, and then also we're also going to have more programming on Wednesday to showcase more of the other sides of Native health. So before we get into the details too far, I want to turn it over to David Lowry and have him give us a statement of relationship. So David, I can stop sharing my screen here.
All right, thank you so much. I'm going to share a PowerPoint slide really quickly. Let's see. All right, so before we begin, I want to thank everybody for joining us and being in relationship with us over the next couple of days, not tomorrow, but today and Wednesday. And I want to offer a statement of relationship. Most of the time you will hear people in higher education in particular give land acknowledgement statements, which that is important, but it should be part of a larger set of conversations about how organizations, universities, healthcare systems, corporations have relationships with and are in community with Indigenous peoples in the United States. So I wanted to start this statement with, in 2021, I tweeted about a conversation at the Harvard Chan School of Public Health that they had about health disparities in COVID. They had a diverse group of health experts discuss COVID and racial discrimination and disenfranchisement. However, I was gravely concerned because the conversation didn't talk about how COVID caused more deaths per 100,000 people in Native America than other racialized minority groups in the United States. Daniel Chande, who's a co-sponsor of our summit, saw my tweet and basically said, David, let's do a conference to express the conditions for why Native America has suffered so badly. And also, let's offer all of us a chance to understand how profoundly invisible American Indian and Native American people are to government, academic, and medical institutions. At that point, we wanted to sort of talk about why Native lives matter at this particular moment during COVID, but also more generally in the world of health and healthcare. We decided to build a stage, which is the summit, for making Native lives matter in a world of social determinants of health, where health is often not defined in Indigenous terms. Indeed, it is in this moment at the beginning of this vitally important summit that I want to give a statement of where we are and where we should go. Our institutions, MIT, Harvard, Mass General Hospital, and Brigham Women's Hospital, are on stolen Massachusetts land. They are on the sacred grounds and paths of several Indian nations, including the Wampanoag, Nipmuc, and other nations that I won't take a moment to mention, but who are very important. Our institutional tentacles, our institutional colonial extractive practices, extend into the Ojibwe and Dakota lands that were seized via the Morrill Act of 1862, the Morrill Act of 1890, and other hostile takeovers that funded MIT and other universities. Our universities, so Harvard and MIT, invested, or our university investments, so for Harvard and MIT, our university investments and our creation, our university investments were part of a creation of corporations and other profitable entities that have placed us in the middle of genocidal campaigns that extend from the railroads of the late 1800s, for which bison were exterminated, for example, to the natural gas and oil pipelines today that MIT students actually design. The Nobel Peace Prize and the Nobel Prize in Economics were named for a man, Alfred Nobel, whose invention, dynamite, was used to decimate indigenous lands throughout the United States. And we can basically, within those contexts, say that American peace and fortune were born in the purposeful silencing of American Indian indigenous peoples. So why does the US have the highest rates of cannabis, opioid, and cocaine use in the world? In part, we must answer this by saying we must be numb as a nation to survive a society that continually practices indigenous disappearance, a nation that can't say our names when it discusses disparities. The silencing of Native peoples affects everyone. It stymies education. It makes healthcare ineffective. It creates conditions of profiteering over environment, conditions that make profiteering more important than environmental health. And we are here today and Wednesday to invite you all to invert this inhumanity, to focus medical education, medical business, and medical entrepreneurship on Native peoples. To do that, as you will see by our many distinguished guests, is to reinvent how we talk about everything from sports where racist mascots are used and they affect Indigenous mental health, to the economics of food, to the ways that our news agencies report. And I'll ask a question in this moment. When's the last time you've ever seen an American Indian or Native American journalist on Good Morning America, World News Tonight, or CNN? When have we been faculty and deans or provosts at your universities, which some of our guests this week are faculty members, but more generally, when do you see us? Let the presences of the Indigenous experts this week be permission to prioritize Native lives and be led by Native peoples. This history is uncomfortable. I will acknowledge that. It's uncomfortable for people who've never heard this. And I've had many students this semester, this year, say, why have we never heard this story? So this is a very uncomfortable history, but we need to take the resources that we have now and move forward towards health equity. As I often say, quote, not only must Natives be at the table is made from stolen Indigenous wood. This means the creation of opportunities for Native voices and identities to be present as we organize medicine and design clinical and non-clinical health spaces. So thank you for joining us for what should be the beginning of health equity and the creation of new relationships. Thank you.
So David, thank you very much for that. So I think that really sets the stage for the day. And what we're talking about, so specifically today we're focused on health and equity. And so there are many disparities seen between Native communities and other communities, but I think it's important to highlight the statistics that we have for this. So, first of all, having health insurance is a disparity for Native American communities. So as we can see on here from this data is that 19% of Natives don't have health care, whereas compared to 9% of the general population. So this makes it difficult for Natives to even enter into the healthcare system when there is a problem, and otherwise would prevent them from having a continuity of care that would also prevent the development of any illnesses or disease in the future. In addition, the mortality is higher in Native American communities. So the percentage of deaths aged before 45 is highest in Native communities, around 25%. And then in African American communities, 15%. And then the lowest in white communities, about 7%. So this just highlights that there are effects of not having health care and that people are dying sooner in Native communities than in other communities. In addition, there is a lack of access. So this is partly due to not having health insurance, but also having inadequate coverage and providers that can provide the healthcare that Native communities need. So you can look at this figure and see that Native communities in the last 12 months, they say that they were always able to get care less often than other populations. In addition, some are never, or sometimes are never able to get care, and that's much higher than the general population. So what is one cause of this disparity is not only the lack of healthcare access and the lack of providers to be treating Native populations, but it's really the Native physician pipeline that isn't as robust as it could be. And so we can see is that many medical schools have zero Native students. So 40% of medical schools in the United States have zero Native students. There are many that have 1 to 3, and then there are very few that have 4 or more. And this is typically in a class size of 100 to 200 medical students. So in addition to that, it's difficult for Natives to get into medical school. And then once they're in medical school, they have a higher likelihood not completing medical school. So you see that compared to white colleagues who will finish medical school, 87% will finish medical school in 4 years. This is only 71% in Native communities. And what this leads to is a disparity in the number of Native physicians that are eventually educated and trained. So you can see out of all the physicians within the United States, only 0.5% are Native. And then in addition, of all the physicians that are Native, there are even a fewer percentage that are on faculty full time. And so you'll see that this is a disparity in that the these Native physicians aren't able to translate what they know and pass it on to and mentor Native students that are in medical school and working through that process of becoming a physician. So at this point, I kind of wanted to give some background and talk about why we want to do this conference. I think David gave us a great introduction to the general overall problems about Native healthcare and inequities that Natives face. And so I think this story is very personal to me. And so this story is very much about my pathway and which really motivated me to want to be a part of this conference and help organize it. And so before I was thinking to go to medical school, I had a very long drawn out process in which I wasn't even sure that I wanted to be a doctor. And it took me a long time to figure out through college, through getting a master's degree, through working in an emergency department to even realize that I want to be a doctor. And so through all of this, I thought about going to medical school. I looked into it, but I really didn't have a good foundation for knowing how to get into medical school. So the first time I applied to medical school, I didn't get into medical school. But I did meet a Native physician, Brian Thompson, who's at Upstate Medical University. And he really mentored me and helped me in my pathway to become a physician. So this was crucial to me to have someone that would serve as a mentor to answer the questions that I had, to put me on the right track, to make sure I was moving in the right direction to figure this out. So eventually I got into medical school. I went to SUNY Upstate in Syracuse. There I did several things, completed several research projects. I brought a pre-admission workshop to Upstate Medical University, which Dr. Welsh will be talking about later. And then all of this, eventually led to me becoming an anesthesia resident at Brigham and Women's Hospital. And so through all this, I think it's important that I have a lot of mentorship that I owe my successes to. In that I was also in a post-bac program that was very helpful for me gaining the skills to be successful in medical school. So I've also been mentoring students and trying to figure out what barriers that they have in order to get into medical school. So I think that moving forward, I wanted to highlight pipeline programs and how successful they are. So, I was someone that didn't get into medical school, and now I'm an anesthesia resident at Harvard Hospital. So I think that these programs are really helpful and successful for people who might not have the exact know-how of where they want to go or how they want to get there, but really have the drive to get there if they're given the chance. So I'll just go over kind of the structure of the day here. So today we have 2 days. We have Monday and Wednesday. They're both from 1 p.m. to about 6 p.m. So today we'll start with Dr. Dabez, Tina, and Dr. Welsh. And so this will talk about programs that are targeting students before medical school. So they have developed programs that are for undergraduates that are looking to go to medical school or other health professions, and to help these students along the path so that they know who to reach out to, what to do to reach their goals. And then we have a few people who are working with Natives during medical school, because it's also important once they get into medical school that Natives are supported so that they can successfully graduate and enter residency wherever they want to go. So Brandon and Dr. Bray will be talking about those kinds of programs to help Native students while they're in medical school. And then after that, we have Dr. Christensen and Dr. Sequist, who are really talking about helping Native communities and having Native physicians work with these communities to bring health equity to Native communities around the United States. After that, it'd be great if everyone could submit questions during the day, and we'll have time for questions at the speaker panel from 5 to about 5:30. And then on Wednesday, I guess I won't go over this in detail, but we have Brent Miracle, so he's a pastor at Christ Revolution Church. He'll be talking to us about religion and how that's important in contributing to Native health. Also, we have Warren and Janelle from Native Lifelines. So this is a group in Boston that really seeks to, that is community-based and seeks to improve the health of Native communities, specifically in Boston. So they'll be talking on Wednesday. In addition, Holly Pilson, she's an orthopedic surgeon at Wake Forest. She'll be talking about the programs that she has been supporting in order to help Native physicians, and especially women, enter orthopedic surgery, which has traditionally not had many underrepresented minorities in it. And then we'll hear from David Lowry again. So he'll give us more information about the disparities that he sees in Native health, in addition to his remarks earlier today. After that, we'll have a speaker panel to talk about, to have all the speakers answer any questions that anyone has from 3:30 to 4 o'clock. And then at 4 o'clock, we'll have Sean Sherman. So he's the sous chef, and he'll be talking about Native cuisine. And then also we'll have the North American traditional indigenous food systems. We'll be talking about Native cuisine and other things that impact Native health. Okay, and also I just wanted to mention that we have support from several groups, some that I've mentioned before, but MIT, Mass General Brigham, and Harvard University. So this is really a big push to figure out how to bring health equity to many communities, but specifically also Native communities. So we're appreciative for their support and guidance along the way. In addition, the Equity and Community Health Center at Mass General Hospital and the Disparity Solutions Center. I already mentioned Native Lifelines here in Boston, and then also the People's Heart. So this is an organization that Dan Chande is involved in, and he's been very helpful in organizing this event.